My name is Dr. Emma Lee. I'm a naturopathic doctor. I practice in Vancouver at a clinic called Clementine. And my practice is primarily women's health. And within that very vast population, my true passion lies in helping those with perimenopause and menopause navigate those decades of their lives. I think it's a population that has been historically really poorly served by not just the conventional healthcare quadrant, but honestly by most healthcare practitioners. And I think there's a shift, and I'm really happy to be part of the shifting tide. So without further ado, we'll dive into herbs for perimenopause. So next slide, please, Amanda. And my apologies, I'm going to be saying next slide a lot just because I'm not actually controlling the slides. Hopefully you can bear with me on that point. So the transition to menopause is definitely one that half of our population goes through. As biological females, we experience a loss in hormones, but menopause is really more about just a loss in estrogen and progesterone. It's about a loss in overall health as well. And the reason why is because every single tissue in our bodies has estrogen and progesterone receptors. And you can see, I know the infographic is probably a little bit too small for you to read depending on your screen size, but the influence of estrogen specifically is vast. Estrogen dictates whether or not we have inflammation in the body, whether or not our skin stays supple, our bone density preservation, brain health, mood and cognitive health, digestion, you name it. It basically has a finger in every single pie. So there's now a lot of research coming out showing that menopause is not just about a loss in vitality and youth, but there's also health concerns associated with the change in hormones. And primarily, we're really looking at these big pieces. So cardiovascular disease, osteoporosis, dementia, type 2 diabetes, and mental health conditions are all associated with menopause in terms of menopause inducing increased risk in various aspects of these health pieces. So next slide, please. What I really love about this particular diagram is if you're not familiar with the stages of reproductive aging workshop staging system, I really recommend you to take a look at this. And the acronym for it is STRAW, STRAW plus 10. So the workshop was initially an initiative that happened in 2001, and it established the basic terminology and staging system to characterize the last 10 to 15 years of a woman's reproductive life. So essentially giving us healthcare practitioners an understanding and an ability to communicate what exactly we're seeing from a timeline perspective and proximity to the last menstrual cycle or last menstrual period. The STRAW, the plus 10, indicates that it was refined in 2011. And so it's now that STRAW plus 10 is now considered the gold standard for characterizing reproductive aging. And I'll refer back to it a little bit throughout the presentation in terms of talking about, when we think about perimenopause as like the 7 to 10 years preceding that last menstrual cycle, what are we exactly talking about? Are we talking about the early perimenopause stage, which is that -2, or are you talking about the late perimenopause stage? And I think it's crucial for us to be specific in our terminology because it allows us to communicate, as you can see, the various shifts in hormones, the sort of like likelihood of certain perimenopausal symptoms being more prevalent. And it allows us to just establish a little bit of a clearer communication across the different professions. All right, so next slide, please, Amanda. When we talk about what's happening in the body from an estrogen and progesterone perspective, I think we have this, for some of us maybe, this kind of image in mind of estradiol remaining relatively high, so E2 or estrogen, the most predominant form of estrogen in the body remaining relatively high in the early or -2 stage of perimenopause, and progesterone being the one that's declining first, which is really, really typical of the average female body. And then it's only near that last menstrual period does estrogen really fall off the cliff. And so I've heard of this being likened to a second teenagehood in terms of the impacts of those hormonal shifts on the body. And how unlike yourself you can feel during these years. And you can see that it's almost like a mirror image of what's happening in the teenagehood, which is a rise in progesterone, kind of a little bit closer to reproductive years. We see kind of that mirror image of a drop in progesterone first before a drop in estrogen. Next slide, please. So one thing that I know I certainly encountered earlier in practice, and a question that I get a lot, is why does it seem like estrogen is very high or can be very volatile in perimenopause, especially if they're getting tested on a serum perspective? And one of the explanations for why elevated serum estradiol levels can occur is due to this phenomenon that's called the luteal out of phase or loop event. So what's happening in the menopause transition or in perimenopause is that there can be really, really elevated FSH and LH, and specifically in regards to that elevated FSH, that can recruit a second follicle to be shot out from one of the ovaries during the luteal phase after the primary ovulation has already occurred. And so as a result, this gives you that pattern of follicular phase-like rise in estradiol in that luteal phase, and then carrying on into the early follicular phase of the subsequent cycle. And this loop event can happen in about a third of perimenopausal women on average. It's roughly, they're estimating from a study and research perspective, that it's happening in about 1 to 4 cycles. It can also be the explanation sometimes as to why menstrual cycles are really irregular as a result of this luteal phase second follicle. The subsequent menstrual cycle can be very, very short, less than 21 days, if there's no ovulation that cycle because of this high estrogen state. Or if there is an ovulation, it can occur quite late, leading to a much longer cycle of over 35 days, closer to 60 days. I just found it fascinating, and it's something that doesn't actually really happen outside of menopause. Okay. So when we're talking about common herbs for perimenopause, I sort of categorize it into these two categories in my mind, and I find it really helpful to dictate, to help kind of formulate what I'm reaching for depending on where that individual is in their perimenopause. So there are the non-phytoestrogenic herbs and then the phytoestrogenic ones. And I typically, not always, and I'll talk about the exceptions, but I typically think about utilizing non-phytoestrogenic herbs in that stage -2, so the early perimenopausal stage where there's still relatively high levels of estrogen, although estrogen is starting to be a little bit more volatile. And then I tend to reach more for the phytoestrogenic herbs in that second, the -1 straw plus 10 stage. Next slide, please. So in early perimenopause, if we're looking specifically at harmonic blends, harmonic arts blends, there are a few that I definitely favor. The liver tincture, TLC tincture, is one of them. And the reason why this tincture I think is so beautiful is because we can think about hormones broadly as kind of production issues, but also as excretion issues. And sometimes when we're thinking about some symptoms of perimenopause, so a very common one that affects about 60 to 80% of women, hot flashes or night sweats, It can be due to volatility in estrogen, not necessarily estrogen levels. So it's that rapid change in estrogen levels. And that, to a certain degree, can definitely be influenced by excretion. So if it's someone who is for sure needing a little bit more liver support for detoxification of hormones, this is one that I reach for. There are virtually no contraindications to the liver TLC tincture. The only theoretical one would be if they're on any medications that really are sensitive to minor changes in dosage. And so you want to be theoretically concerned with anything that changes liver detoxification enzyme kind of capacity. But otherwise, it's a really beautiful, gentle tincture that can be taken long term. And I do recommend that patients stay on it throughout their entire perimenopause, kind of early menopause lifespan, just because it can be so helpful with not just detoxing of endogenous hormones, but if they eventually go on hormone replacement therapy, this is a really nice one too. Vitex is my other go-to when it comes to early changes in menstrual cycles. So variations of menstrual cycle length by less than 7 days. I find that Vitex can be sufficient in and of itself to stabilize those menstrual irregularities. It works as a reminder, not necessarily directly on increasing progesterone, but rather influencing dopamine, LH, and FSH levels, and then having the body HPO axis communicate a little bit more efficiently so that the progesterone production is a little bit more robust because ovulation was robust. So this one I love, love, love. I use it all the time in my female population when it comes to menstrual cycle irregularities. The one caution that I would recommend that you keep in mind would be if there's any history of PCOS, because for a lot of those PCOS patients, Vitex can aggravate their condition. Next slide, please. So we didn't really talk too much, and I feel like I'm going kind of a mile a minute, and I'm aware that I'm talking very fast. At least for me, it feels like it. And we certainly didn't really talk about the symptoms of perimenopause, but very, very common ones that I see in addition to hot flashes and or night sweats are changes in mood. So increase in irritability, anxiety, decrease in stress resilience is definitely one that is very, very common in my patient populations. And changes in weight, so creeping weight gain and increasing hemoglobin A1C, if they're being monitored, are very common complaints of perimenopause. And so if we're thinking outside of hormone influences and thinking about kind of that bigger toolbox that we have from a herbal botanical perspective, St. John's wort is a beautiful one for that mood piece. And then bitter melon tincture, I really, really like for really mild dysregulation in blood sugars. Next slide, please. And from a dietary perspective, I always think about what we can do so that we're not so supplement heavy and that a person feels like they are doing something on a regular basis beyond taking an agent that's positively influencing their health. So we're not going to talk about lifestyle at all. We're not going to talk about exercise, even though that's such a huge piece of it. But purely from a dietary perspective, I really like seed cycling for the very, very early perimenopause. It's kind of like the Vitex from a dietary lens, and it helps to regulate estrogen production when estrogen should be high and support progesterone production when progesterone should be high, which is in the second half of the cycle. So it's purely just a combination of different seeds and grain or seeds primarily. So those high in EPA for this first half of the cycle, and then those high in GLA to help support progesterone production in the second half of the cycle. And I would say always counsel your patients to do this diligently for 3 months before assessing whether or not it's working for them or positively influencing their hormonal picture, because diet as medicine or food as medicine can definitely be a little bit more of a gentle course of action and take a little bit longer. Next slide, please. All right, so if we're moving on from the -2 straw plus 10 stage to this late perimenopause where there's more volatility in menstrual cycle length, we can kind of deduce that ovulation isn't happening as regularly, that there's more variations in estrogen and perhaps a lower estrogenic environment on average, and for sure more significant decrease in progesterone compared to the early perimenopause. We can move on to more of the phytoestrogenic herbs and dietary measures as well. So the female harmony tincture blend, I don't necessarily always reserve it for the late perimenopausal stage, but if we're comparing through all of the Harmonic Arts products, this is definitely the one that's a little bit more phytoestrogenic because of the Dong Quai and motherwort content. So both of those are phytoestrogens or contain phytoestrogens. And this one, I would say the two primary cautions that I keep in mind are if there's any type of menorrhagia, so really, really heavy bleeding, and also to kind of be wary of long-term use. So we don't want to use it if there's heavy bleeding because Dong Quai is an anti-thrombotic agent, and the Oregon grape content of it, it's a little bit more antimicrobial, although the dosing isn't the same as if we're saying, like Oregon grape dosages for, let's say, something like SIBO. But for sure, we'd want to be wary of this for like long-term, months and months on end, and for sure, definitely not year-long usage. But to see whether or not we can get a little bit of movement in a positive direction with herbals alone, this would be a really great agent. Really, really wonderful if there's a lot of menstrual discomfort with periods because of that blue cohosh and even the black cohosh as well. I should mention that one interesting thing about the black cohosh is that there's now recent debate as to whether or not it's as useful for, let's say, increasing fertility. But there is older research showing that racemosa is actually quite powerful in terms of LH inhibition, and there is I would say an application for it in PCOS patients is that if there's concerns with wanting to increase fertility in the perimenopausal stage, this might be something that you want to consider because there has been a research, only 100 women, but an RCT with 100 women with PCOS. And it was done comparing 40 milligrams of black cohosh delivered POQD for 10 consecutive days versus 100 milligrams POQD of clomiphene for 5 days for 3 consecutive menstrual cycles. And fertility rates were compared, and there were higher pregnancies or higher rates of pregnancies in the black cohosh cohort versus the clomiphene cohort. I think it was like 7 versus 4, something like that. It's a very, very nice one if you have an older woman wanting to get pregnant but is already in the perimenopausal realm. Okay, next slide, please. All right. So similarly, we can also think about phytoestrogens from a dietary perspective. I know a lot of us, especially if we went through more of like a nutrition program or a naturopathic medicine program, that we learned about phytoestrogens in diet as being really beneficial for things like bone density preservation, cancer prevention, for increasing vaginal lubrication, for urogenital, symptoms of perimenopause. However, that's also being disputed a little bit from a research perspective, but the research stands firm specifically on reduction of total cholesterol, LDL cholesterol, triglycerides, and increasing HDL. And this is a very, very common pattern, is dyslipidemia in perimenopause and menopause. And so I do love talking about phytoestrogens. Soy, flax seeds are the my main go-tos. I typically recommend them to aim for 50 to 150 milligrams of isoflavones per day. And that chart I find very useful because it gives you an idea of how much, let's say like tempeh or tofu you would need to consume to get to that like average 100 milligrams per day. And it roughly looks like basically replacing one of your protein sources from an animal protein to soy protein. I love flax seeds because it also has the capacity to bind up any estrogens or progesterones that need to be detoxed from the body. So that's a good one too. Okay. So when we're talking about late perimenopause, in addition to the hormones estrogen and progesterone, there's also a change in DHEA that we see in women, and that's really indicative of shifts happening with the adrenal function as well. And so I do like to think about what else can we do in addition to phytoestrogens. Ashwagandha is one that I reach for time and time again. I love it as a standalone adaptogen. It really works so well for that like restlessness, insomnia, whether it be sleep onset or sleep maintenance, or like changes in cortisol patterns that we see with decreased stress resilience. And so this is one that I think is safe and effective across the board. It also has a lot of research showing benefits in terms of helping decrease mild to moderate hot flashes during perimenopause. So this is something that I think can be very successfully added to a lot of different treatment plans. Next slide. And this is what I mean by changes in DHEA, is that from a research perspective, there was a study called the SWAN study, which is a study of women's health across the nation, and by the nation they mean the United States, that took a look at DHEAS levels in serum in females from pre-menstrual or pre-perimenopause through the perimenopause transition to late postmenopause. And we see that there's a spike in DHEAS in that perimenopause, especially concentrated around that last menstrual period timeline. And it's indicative of just the adrenal glands going into hyperfunction. And so I think there's a lot of support that we can do from more of a holistic standpoint than just thinking purely about estrogen and progesterone to help with that stress resilience piece. And lastly, I should mention that ashwagandha has been shown to also significantly benefit anxiety. And I think it's through this mechanism as well as to increase that adrenal hyperfunctioning piece. Next slide, please. Okay. So just to quickly touch on this, because this is a huge component of the late perimenopause, early postmenopause period, is this concern with loss of bone density. Isoflavones still, from a dietary perspective, is our primary go-to, even though the research is now a little bit more conflicted. And this is just a little bit of a reference slide for you in terms of what I would typically recommend from a plant's perspective. I like it in like whole foods form from like a nettles perspective, but also like a tea perspective. The red raspberry leaves tea can be really beautiful, but just as a reminder that it needs to be it also needs to be volatile oil extraction as well. And so making sure that they're dripping the condensation back into their cup can be really helpful. Okay, next slide, please. All right, so we talked a lot about herbs. What about HRT? I am a huge proponent of hormone replacement therapy. It is, I think, a very crucial discussion that we need to have as a healthcare practitioner with a patient that's going through perimenopause because of the upsurgence in the research indicating potential benefits with hormone replacement, and I'm talking about bioidentical estrogen and progesterone. So a couple of resources that are really helpful for you if you're not familiar with them yet. Newson Health in the UK does a beautiful job of condensing the information specifically regarding risk stratification and benefit stratification, comparing women who've never received hormone replacement therapy, women who received synthetic versus women who received bioidentical. And this is just a little bit of a screen grab showing all-cause mortality. That first row is if we're taking a look at average 1,000 women aged 50 to 59, no hormone replacement whatsoever, we can estimate there'll be about 7 deaths happening per year. And then the second line is with oral estrogen and synthetic progestogen. There's 2 less deaths per 1,000 women. And then if we're taking a look at bioidentical, then there's 2.5 fewer deaths. And then you can go through kind of all their benefits and all their side effects as well. Type and timing definitely matters, and this is the bulk of my conversation when it comes to hormone replacement therapy is identifying if there are any contraindications. So screening is really crucial, but also talking about the different options available to that person. And the beauty about kind of our availability when it comes to options is that it can be customized medicine, and I find that patients do better if we really customize to, let's say, hormone replacement therapy looks different if you're in early perimenopause and you've tried lots of different things and nothing's worked versus you're already 5 years into menopause. The type and the dosage is definitely different for those two individuals. One last thing on this slide is I haven't had the chance to update this presentation because this research is so new, but there was a study that was just put forth earlier this month, so early April 2024. It's a retrospective study taking a look at 10 million women, recipients of Medicare, so specifically American women, comparing women age 65 who've stayed on hormone replacement therapy versus women age 65 who never received any hormone therapy whatsoever. And they've shown unequivocally an improvement in risk profiles when it comes to all the main things that we talked about on that very first slide: cardiovascular disease, heart attacks, strokes, cancers, including breast cancer, which is a huge one because of the conflicting results that we've had in the past from like the Women's Health Initiative, for example. And then osteoporosis concerns, dementia, etc. So really, really, really beautiful study that does a good job of summarizing and hopefully dispelling fears around hormone replacement therapy. If you want to take a look at it, it's for free on PubMed in terms of the entire research article. All right, next slide, please. Okay, so rapid fire a couple of studies. So the first one is one that is, I think, one that all of us have seen very, very frequently is someone who comes in to see you, and in this case, it's a 42-year-old female, and she's saying, I just feel like I'm out of control, or my body's out of control. I don't feel like myself. I've had creeping weight gain despite like eating cleanly and regularly exercising and doing all the right things that I know I should be doing, decreasing stress. I'm experiencing hot flashes and night sweats. Brain fog is another really common symptom that I hear about. Anxiety, irritability, loss of libido. And then on blood work, I'm showing, like hypercholesterolemia, and I just don't know what to do. So the confounding variable here is that she's still using a hormonal contraceptive. She's on a Kyleena IUD, and her cycles have been kept regular at 25 to 28 days. And so we don't really know where she is along the perimenopausal spectrum, but from an age perspective, she's certainly on the early side. So upon initial visit, the workup and plan is that I refer for further testing to get a better understanding of her baseline. So I often refer people out for what's called the DEXA plus full body health scan at Body Comp, which is a local company. The full body health scan allows us to take a look at lean body mass, adiposity, but more importantly, visceral adiposity, which is a great way of measuring risk factors for cardiovascular disease. I also referred her to get some blood work done. So the insulin tolerance test, which some of us know as the oral glucose challenge test, it measures glucose in response to a big dose of glucose, but also insulin in response to that. And then I was very, very kind of unhesitant with prescribing Perimetrum 100 milligrams at bedtime, because I just find that that's a very nice initiation into progesterone. Progesterone is very, very safe. I prescribe it all the time in pregnancy for miscarriage prevention, and there's just a lot of long-standing data regarding safety. My primary concerns are aggravations of acne, if that's a struggle, and then headaches is another one, and bloating can be an issue as well. So on first follow-up, she reported that the mood and the hot flashes and night sweats improved with addition of Perimetrum alone. We got her body DEXA scan and full body health scan back, and her visceral adiposity tissue estimation is at 837 grams, which is very high. I'm concerned whenever it's past 400, and so this is definitely kind of triggering me to the fact that there can be some concerns with that hypercholesterolemia from a cardiovascular standpoint, and we may need to be a little bit more aggressive with that. And then there's mild insulin insensitivity on that blood work of insulin tolerance test. So we decided to continue on Perimetrum. We introduced a liver support from a herbal perspective. We added berberine for blood sugar regulation. And then I also talked to her about time-restricted eating and tracking food insulin demand. And on her second visit, she reported a weight loss of 10 pounds. She did get her Kyleena IUD removed, and she had had no period for 8 weeks. Libido is still low. Stress is still high. With the 8 weeks of no menstrual period, I say typically give it 3 months before we kind of see what the body is like after the removal of a hormonal contraceptive. But I definitely kind of kept note of that, and I wanted to think about maybe introducing ashwagandha in this particular individual, and then potentially layering on biased if there's no change in the loss of menstrual cycles. Okay, next slide, please. So the second case is a case of late perimenopause, and this was a 48-year-old female who came to see me, and she said right off the bat, she's like, I am absolutely not interested in hormone replacement therapy whatsoever. I just want to do everything as natural as possible. She reported a lot of irregularity in a very short amount of time. So periods every 5 months in 2023. Previously were very, very regular at every 3 weeks. And then she's starting to experiencing hot flashes, night sweats, and a lot of joint aches and pains and mild weight gain. Another kind of findings that she had iron deficiency, but she's supplementing with oral supplementation, and so it's improving slowly. So the plan was that I talked to her about all her options when it comes to a non-hormone replacement perspective from a herbal perspective. And even though I didn't think Vitex would do much for her, she really wanted to give it a go because she liked the kind of like mechanism of action of Vitex. And so we did 500 milligrams POQD, and then same thing, referral for Body Comp DEXA with full body health scan. And so on her first follow-up, she said absolutely no change in hot flashes and night sweats, and the Vitex basically made her feel bloated and not great, and so we discontinued it. We then trialed the Room Rapodicum, which is false raspberry. 8 milligrams POBID. There's a lot of research on this particular herb. I know we haven't touched on it yet, but a lot of research in regards to efficacy, specifically in helping with hot flashes and night sweats. And so I wanted to give that a go because that was her most bothersome symptom. But we did definitely continue talking about how a lot of these herbal prescriptions can only do so much in terms of a long-term healthy aging perspective and for decreasing risk factors for cardiovascular disease, osteoporosis. So it's not something that if I hear someone say they're not interested in hormone replacement therapy, that I just kind of don't talk about. I always try to see whether or not it's coming from a fear basis or a misinformation basis, or if it's truly valid in the case of, if let's say they have active breast cancer, recent breast cancer, et cetera. So I always have a much longer and detailed conversation about an individual on hormone or regarding hormone replacement therapy. And then on her second follow-up visit, she definitely saw improvements in hot flashes and night sweats. And we're just continuing the course, and we're going to kind of continue exploring her threshold for hormone replacement therapy. And that brings us to the end of our presentation. And I know that I forgot to mention this, but I'm hoping that some of you had questions and that you submitted it via chat. And I welcome Amanda to open up the chat line or to let me know what questions came through.
Hi, Emma. Thank you for that amazing presentation. I have one question to ask just to confirm, to bring clarity to one thing that you shared regarding the hormone replacement therapy in the study that you cited. Was that that the folks who had been on hormone replacement therapy were at a decreased risk of all of the health conditions that you noted, right, compared to the folks who were not on any kind of hormone replacement therapy? Okay.
That's correct. Yeah. And it's a nuanced discussion because, like I said, you do have to screen for contraindications, but that study alone should at least open the door to having that conversation because it is a very, very robust data set. It's 10 million women, and it's not the only study. This is just the most recent one. There's definitely been a shift in, I think, the tolerance for hormone replacement therapy because there has been such robust and concrete data showing benefits with hormone replacement therapy that's come out over the last couple of decades.
Great, thank you. And so I just want to go back to the slide to share where folks can find you at clementinenaturalhealth.com. That's located in Vancouver, BC. And also to invite folks to visit harmonicarts.ca to learn more about our tinctures, our single tinctures, as well as our tincture blends that were noted in the presentation. Also, we have Miranda, our inside sales rep, who is in contact with our wholesale practitioners, and we are having a discount right now on all tinctures. So that's 10% off of our single tinctures, our tincture blends, as well as our mushroom tinctures. And in order to receive that discount, you have to reach out to inside sales at harmonicarts.ca and connect with Miranda directly. I want to thank you for your time, Emma, for this great presentation. And thank you for all who attended. And this will be recorded and shared with the rest of our practitioners.
Thank you so much for having me, and have a great evening.
Good night, everyone.